This lesson is about how to do telemedicine. While the tactics and execution of doing a video-based encounter through a webcam is vastly different than being in the room with the patient, the subject of next lesson, the whole point of this lesson is to show you that the path of clinical reasoning, the determining the diagnosis and deciding on a treatment, the physician's work of the physician's job, is so close to the same that what we should be doing when someone asks, how do you do telemedicine, is actually answering the question, what do you need to do differently during the encounter? Not how to do telemedicine, because if you know how to do your job well, you already know how to do telemedicine. If you know how to do medicine, you know how to do telemedicine. So what you're going to see in this lesson is a lot of stuff you probably are familiar with, especially if you've done the boot camp. You're going to see elements that have their own title. I'm going to incorporate them because there is one major change in telemedicine. And we are also assuming that telemedicine means what telemedicine means today at the time of this recording. For the most part, what that means is a video-based encounter with an individual in a different location, sitting at their home, using their computer or phone to communicate with a physician who's not present in that building, also using a computer and phone. Video-based encounter. So, the screen comes on, there's the patient. What happens? See if this sounds familiar. A patient is going to present of a chief complaint. And then you are going to do the first paragraph. So called the first paragraph because it will be the first paragraph of your history and physical in the documented document. The first paragraph is done every patient every time. It provides you with a timing and characterization of the complaint. At Tulane, where I trained and taught, we used far colder. I don't care what you use, wheelbarrow, not a mnemonic at all, so long as you have some method for acquiring the information from a patient based on their chief complaint. Timing and characterization. Far colder stands for frequency, A, associated symptoms, R, radiates, C, character or quality, O, onset, L, location, D, duration, E, exacerbating factors, and R, relieving factors. Now, of course, you're not going to ask the location of dyspnea. Right, but this is a mechanism for ensuring you get all the information you need from the patient about their chief complaint in order to pass that through your filter and develop the differential diagnosis. Now, I am an internist, and so I see adult internal medicine problems. In the intern content, the free stuff, I have methods. And they're advanced organizers or mnemonics that allow you to have a long list based on the chief complaint alone. By acquiring the timing and characterization of a complaint and passing it through your knowledge of patterns and prevalence, you can then whittle down that long list to a short 5. And based on that differential diagnosis, you're then going to do things in the history and the physical and labs that are going to increase or decrease the pretest probability of the things on your differential. Just because they're on the long list doesn't mean they need to be considered. And what's going to happen is ideally you're going to bring 1 or 2 to the top very early on in the process of clinical reasoning such that the labs aren't even necessary. Based on the differential diagnosis, you are then going to ask some questions that will constitute the second paragraph of the history and physical. The second paragraph is the review of systems questions that increases or decreases the probability of the things on your differential diagnosis. You do not walk through a laundry list of review of symptoms questions in the path of clinical reasoning. If you want to bill a level 3 inpatient visit or a level 5 clinic visit, you need to include all of those in your documentation. Right? But when someone says review of systems, in this context, I don't mean all of the questions. I mean only the 2 or 3 questions associated with the things on your differential that are going to increase or decrease the pretest probability. That is the review of systems that changes probability. This is going to inform your differential diagnosis, increasing or decreasing the chances that the thing on your list is it. And like an old school train station where the cars would, as one becomes more likely, it gets ahead of the other, and then thus the other one must fall. Every question you ask, the answer has a positive or negative likelihood ratio associated with it. And based on the answer to your questions, some diagnoses should become more likely, others less. On the H&P form, you've got the bullshit in between. This does not enter into the path of clinical reasoning. It's not that it isn't important, it's that it's not relevant to getting from the complaint to the diagnosis. Because if it were, anything in the star should be brought into the second paragraph. The star represents the past medical history, past surgical history, family history, social history, allergies, and meds. This information is not going to be useless. It's just that you don't need to fill out all the form in order to incorporate it into the path of clinical reasoning. Based on the differential diagnosis, you're then going to select physical exam maneuvers. There are Tier 1 exam maneuvers, every patient, every time, and there are focused exam maneuvers, Tier 2. My Tier 1 exam is not the same as a pediatrician's, it's not the same as a gastroenterologist or a cardiologist. A gynecologist's Tier 1 exam is not the same thing as a neurologist. Each provider has their own Tier 1 exam, every patient, every time. But then based on the differential diagnosis, just as you had a Tier 1 first paragraph and a Tier 2 second paragraph in the history, so too you have a Tier 1 every patient, every time, Tier 2 exam based on your differential. And the results of the physical will then influence your differential diagnosis. But wait, we're talking about telemedicine, video-based encounter. This is going to be the subject of our discussion today because most of the physical exam maneuvers can't be done via video conferencing. And this is the thing that's different. You may have noticed I didn't say in the encounter or the video-based encounter until this point, because taking a history involves your mouth and your ears. Getting labs and making a decision requires a computer. Have those in a video-based conferencing. The only difference, physical exam. We'll come back to this. Let's finish off the path of clinical reasoning. Based on the information you've gathered so far, you generally should have a pretty good idea. You're going to get some labs to confirm, which will ultimately influence your differential diagnosis. And out the bottom comes the diagnosis. And based on that diagnosis, you treat. Now notice, everything evolves around the differential diagnosis, and everything spawns from it and to it. That is, the questions you ask are based on the differential, and they alter the probability of those things on the differential. The physical exam is directed by the differential diagnosis, and so too will it inform the differential. The labs are the same thing. They also have a Tier 1 and a Tier 2. But let's go back to the physical exam. The physical exam usually involves palpation, percussion, auscultation, maybe vital signs, and observation. You are not present. You cannot palpate. You cannot percuss. You cannot auscultate. And sometimes you might not even have vital signs, depending on the way your EMR is set up. If you've chosen to do sort of an acute care round robin, see whoever you see, and you don't have that information ahead of time, you have no chart, you may not have vital signs of the person's contacting you from home. You may not need them though. The only thing then you can do using a video camera is listen to the general environment and look with your eyes. And that is key. Eyes. Use your eyes. Simple things like mental status. Are they GCS 15? Are they communicating with you normally? Are they inebriated? Those things are going to be pretty obvious and generally don't matter for the path of clinical reasoning. Right? They're contacting you with a chief complaint. We're going to assume that this person is with it because they've logged onto a computer, signed into the thing, got their video camera working, managed to unmute themselves. They're probably already with it. So you can't do any of this stuff, but you want to. You are not going to be able to train a patient to do a test for an acidic wave of the abdomen, right? Physical exam maneuvers are only useful when they're done well. Training a medical student or a resident how to percuss properly can sometimes be difficult. It's unlikely the person who's contacting you for a telemedicine visit is going to be able to be trained on how to do it. So you have to rely on the things that you can observe with your eyes. But because you're using technology, you need to be creative. And you need to coach. You're sitting in front of a camera. They want to show you their butt. You're going to need to get them to get into a position where they can pull down their pants and show their butt to the camera and have it be in focus. The skill set is going to be helping them do what you need them to do to get the information that you need. If you've ever been on a video conference before, it can be very difficult just getting a piece of paper in focus that you want to show. But physical exam is all about using your eyes. It's the only thing you can use. You can get them into a position so you can actually look for JVD, right? You can get them in a position so that you can see their butt. But it's all about positioning and seeing only. And so what happens if you need a physical exam? If you need a physical exam, they have to be referred. The question becomes, though, do they need it? And how do you decide? Now, the message I'm going to deliver is a dangerous one. I do not want you to hear the physical exam doesn't matter. Touching the person with your hand, if touching is appropriate and done the right way, not only gives you diagnostic information, it also establishes a personal connection. It breaks the glass screen. Just the handshake at the beginning of an encounter may be enough to win them over to your side. By not being able to touch someone, you lose more than information on clinical reasoning. And so doing the physical is always part of the task. In telemedicine, you can't. In a live encounter, you must. Even if you don't get any information from that, the fact that you're doing it communicates to the patient, you're paying attention, you're looking for something. It gives reassurance. You can't do that in telemedicine. So how do you decide whether a physical exam test is needed? Well, that is going to be based on Bayesian reasoning, which I'm going to go over very briefly. I know math. And treatment thresholds. The way Bayesian reasoning works is you have a pre-thing probability. We call it a pre-test probability. The diagnosis is so likely. Then you do something. And I'm going to say something as something. It's a thing. A thing could be a question. A thing could be a physical exam. It could be a laboratory. And based on the result of that thing, you're going to have a post-test probability. This is me saying the same thing as you ask questions that are going to increase or decrease the pretest probability based on the response. You're going to do physical exam maneuvers that are going to increase or decrease the pretest probability based on the findings. Pretest probability, do a thing, get a post-test probability. Each thing has what's called a likelihood ratio. How good that maneuver or question or lab is. A positive likelihood ratio says if you find this thing to be positive, it is this much more likely to be the diagnosis. And generally, positive likelihood ratios are assembled like this. Some number that's 1, it's going to get to 0, but never does. It's going to be a descending value less than 1, close to 0. This thing, this side of a likelihood ratio is very difficult to understand, and I'm not even going to say what the meaning is because all I care about is the other side. And it goes up to a pretty high number. To the right of this bar means that if you find something, it is more likely that they have that diagnosis. Every test, everything has a likelihood ratio associated with a diagnosis. A test doesn't have a likelihood ratio. A test, a thing, has a likelihood ratio for a diagnosis. Let's just do this without math, one that you're probably familiar with, the troponin I. A troponin I that is positive has a likelihood ratio of 10. That's a really good number. One thing having a likelihood ratio of 10, 10's big. They probably got a heart attack. But does a troponin I mean they have a heart attack? Well, if they have substernal crushing chest pain, are pale, cool, and diaphoretic with a sense of impending doom, with a past medical history of hypertension, diabetes, dyslipidemia, smoking, and a prior myocardial infarction for which they're on aspirin, statin, beta blocker, ACE inhibitor, and nitroglycerin, and the chest pain was the same as it was last time, yes, that troponin tells you they have a heart attack. But if that person is 24 years old, has had a history of DVT before, who with a history of hypercoagulability, who hasn't taken her anticoagulation because her insurance got canceled, you don't have to do the physical exam. That troponin tells you that's a pulmonary embolism. So the troponin doesn't tell you a diagnosis. It tells you the diagnosis in context. What else has a positive likelihood ratio of 10? If someone presents with dyspnea on exertion and paroxysmal nocturnal dyspnea and orthopnea, they're all positive. If these are all positive together, they have a positive likelihood ratio of 10 for CHF. That 10 green troponin is for MI. What's interesting is that you can do this in the opposite. You can have a negative likelihood ratio. And it's set up the same way. That is, if they don't have the findings, they are that much more likely to not have the diagnosis. This is a little bit of a fudge, but I'm doing it for emphasis. If you have negative dyspnea on exertion and negative paroxysmal nocturnal dyspnea and negative orthopnea, they're all negative. The negative likelihood ratio is 10 for CHF. If they have these three elements of their history, it is extremely likely that they have CHF. The other thing it could be is a pleural effusion, not related to CHF. If they don't have these things, they don't have CHF. And notice what's not on here, a physical exam maneuver. Because physical exam maneuvers are important for the reasons I've already discussed. Some of them actually have pretty good likelihood ratios. But the thing is, if you perform a physical exam wrong, the likelihood ratio is going to be both positive and negative 1. If you have a likelihood ratio of 1, it means coin flip. Shouldn't even bother with it in the first place. It doesn't matter. This is Bayesian reasoning. Do you need the physical exam? Well, if it's going to help you make the difference between one diagnosis and another, yeah, you need it. And if you need it in telemedicine, you have to refer out. Enter treatment thresholds. On the left is 0%, on the right is 100%. This is your post-test probability. What this comes down to is step. whenever you choose to do something, it has to be based on these 4 principles: safety, tolerability, efficacy, and price. Asking a question, doing a physical exam maneuver, you have to be okay with a 0% probability to do that. It's not without cost and not without safety. But in order to do a physical exam maneuver or ask a question, you don't have to be very certain at all. In fact, you start off by asking questions because you're not certain at all. You have no idea what the diagnosis is. But should you be doing a Koenig and Brzezinski maneuver for meningitis on someone with crushing chest pain and ST segment elevations? Probably not. They should be in the cath lab. Right? So it's not 0, but it's pretty close. There's only very few things that you need to be absolutely certain before you treat because the cost is so high. The classic example of this is chemotherapy. It is not safe. It's more likely to kill them than it is to save them. It's not tolerable at all. It's terrible side effects of all kinds. It's not very efficacious. If you're on chemo, you're only trying to buy yourself time. Now, not always, of course, but in general, yes. Price astronomically high, and they keep coming out with new drugs to keep the prices very high. Chemo sucks at step. It's the only option. But if you're going to use chemo because it's so bad on step, you need to be 100% sure that you have the right diagnosis to give someone chemo, which is why you need a biopsy before you give someone such a toxic treatment. Then there's 2 others. One is, I am going to treat. The other is, I'm going to refer for the physical. Enter the complexities of telemedicine. What makes this discussion very interesting is the COVID epi/pandemic, where we had to shelter from home and people were using telemedicine as their only medicine. You see, before that, there was a discussion of, is the pretest probability high enough to ask a question or do a physical if you're in person? The answer is almost always yes, except for that Koenig-Brzezinski maneuver. Right? The cost is so low, and the benefit so high, and of course you're going to do a physical. That's why it's baked into the process. But you add on the complexity of telemedicine. There's going to be some times when you are sure enough that you need that physical, but not sure enough that you're just going to treat without having that physical, where you do need to refer them. Before shelter from home, there was a point where above the treatment threshold, you don't need the physical exam because you're so sure of the diagnosis, you're just going to treat it anyway. But then, what about the cost of breaking quarantine? Is that bar less than treatment or higher than treatment? Enter the 2 complexities of all of this process. What is the actual probability? Means also what is your actual treatment threshold, and heuristics. And all of this process is very nice. You have a pretest, you apply some number, and you get a post-test, right? Great. What's the pretest probability? No idea. You make it up. And this isn't a nice plug and chug, make it a table. Right? There's no way to automate this. This is experience. You're going to ask different questions and do different physical, get some labs. That's going to set your own concept of where the probability is. And no one has this written out. There's no numbers except 0 for asking a question and 100 for chemo. You're going to have to make that judgment. There's no hard and fast way to do it, but using this concept, you can see it's not just simple as pass the buck and refer for a physical because you can't do one. It's, does that actually matter? Because if the likelihood ratio isn't very good, close to 1, but it has value, you should do it if the step is low. Right? If it's safe, tolerability, efficacy, and it costs nothing because the person's in front of you, you should do it. But if your pretest probability for bacterial sinusitis is so low, you know it's just viral sinusitis, then you really want to tap on someone's face because that's what you've been trained to do you really need to tap on their face? If they're in front of you, you should do it because it doesn't cost anything. But should you deny that person reassurance, the treatment for a viral sinusitis, and insist that they break quarantine to go have someone tap on their face? Of course not. And if they've got purulent sinus drainage coming out of their nose and they're febrile and they had a viral sinusitis last week, do you need to tap on their face? If they were in front of you, you would. But now, no, you don't. You're just going to treat them. Call them in antibiotics. Let them go get their antibiotics and treat their bacterial sinusitis. And so it becomes much more nebulous than you'd want it to. The second thing is heuristics, and this happens all the time. Because it's more dangerous, I have to rule it out. No, you don't. Just because it's deadly doesn't make it more likely. That's the practice pattern we have because we have CYA and patients present to the ER the ER has no idea who they are and they have to start from scratch. And rather than be sued, they do this practice pattern. Now, ER is not the only people who do it, but that's where you see this a lot. Because it's more deadly, I have to rule it out. Got a rash there. Yeah. Did you rule out anthrax? No. How about smallpox? Smallpox causes a rash and it's always fatal. Of course you don't rule out smallpox. Pattern and prevalence is not prevalent at all. The prevalence is 0. So just because something's more dangerous does not mean you have to rule it out. Everyone else has it, they must have it too, given the viral outbreak. No, they don't. Just because you've seen it recently doesn't make it more likely that this patient has it. Now, if they were told, I was exposed to COVID-19 by 8 people in my jail cell 2 weeks ago, that goes into the timing and characterization and the second paragraph, right? Not into your subconscious clinical reasoning. I'm going to close with something that people have also brought up on the web. In telemedicine, there's the time before the encounter, and there's time after the encounter. Pre-encounter, you may have access to EHR. You may have a chart. Or you may not. Depends on how your system's set up. That's called like all the time. After the encounter, see if this sounds familiar. You're going to write a note. You're going to place orders into a computer, sitting at a computer, looking at a computer screen. That's called every encounter now. Sometimes it's even intra-counter, not just post. And if you're an attending, you're also going to put a bill in. Guess how? At the computer. It feels like telemedicine has a lot of time in front of a computer. You know what also had a lot of time in front of a computer? My practice. An hour in the morning with the nursing staff, 2 hours on rounds with residents, 5 hours in front of a computer screen, signing notes, checking on orders, making sure the results were there, not checking in on my residents' work, and then billing. The point of this is the path of clinical reasoning. All the things you're going to do, telemedicine, are the same thing as medicine. If you're a good doctor, you're a good teledoctor. The only intricacies come in to the physical, where you want to do things, but you can't. And so you have to decide not just I would do them, but do I need to do them based on my probabilities and my treatment thresholds? All the while considering STEP as the evaluation tool and not falling into cognitive heuristics. That is the path of clinical reasoning in telemedicine.